So now let us start with this fancy topic called as evidence-based medicine. If you are a UG student or still in your graduation days, this topic you can study and boast around that you know so many things. But in case you are preparing for your PG entrance exam, there are few MCQs here and there which can be asked. So just before I start beginning the MCQs, a basic understanding, what do you actually mean by evidence-based medicine? See, let us say you already know that there are so many vaccines for COVID-19. We are talking about COVID-19. Let us say researcher one from India, they developed a new vaccine and they started a clinical trial on that. Then researcher two from China, they did US, Namibia, Cuba, Mexico, Germany, England. They did so many researches. So you have so many researches now. If you take all the researches, combine it with everybody's experience, what age group did they take, what vaccine did they do, and then don't you think you can come out with the final best answer? So mind it, what I'm trying to say is that I'm not saying that we'll do a observation study design or descriptive or analytical study design or experimental. Now it's not doctor patient. It is doing listen to the words, it is doing a study of the studies. So studies which have already been conducted along with the experience of the researchers, along with the clinical trials, along with the case reports, everything you combine together, and then you do a study that is called as evidence-based medicine. Evidence-based medicine is just 15 years old science that we are talking of. The father of evidence-based medicine is Dr. David Sackett. It is Dr. David Sackett. So MCQ start now. First MCQ, what do you mean by evidence-based medicine? What are you going to study in evidence-based medicine? In evidence-based medicine, we need to study two things. What do you mean by systematic reviews and what is meta-analysis? What do you mean by systematic reviews? It is a preliminary study. It is a preliminary study to evaluate the effect of a factor. This factor could be a risk factor or it could be a protective factor. To evaluate the effect of a factor or an intervention, it is called as a systematic review. So there is a system in which you study the studies. So you take study 1, you evaluate what is the age, and study 2 and study 3. So you systematically study. What do you mean by meta-analysis? Meta-analysis is a step further. So what do you mean by meta-analysis? It is a statistical approach. Highlight the word statistical approach. Highlight the word approach. Statistical approach. It is a statistical approach to evaluate the final effect. Highlight the word final. To evaluate the final effect of an intervention, usually an intervention or a drug or vaccine or any factor. So just highlight the word. It is a statistical approach to find the final effect. So which of the following is the best measure? Of course, the answer has to be meta-analysis. The next point that we can study is like what are the ways or what are the steps to do a evidence-based medicine. Either it could be a systematic review or meta-analysis. So first and foremost is that we have to plan. You have to see that what you are going to study. Why do you want to do this study, and how and where are you going to do? So how and where means that what is the method that you are going to adopt? Why is that, like, what is the need, and what is exactly what you want to achieve by doing a meta-analysis? So try understanding that this MCQ has been asked that which is the most critical step. Please note that formulation of what you want to study and why do you want to study. This is the most critical step. This is MCQ. It has been asked previously. This is MCQ, which is the most critical step in doing evidence-based medicine. It is not about the research methodology. It is about what you want to study and why do you want to study. So the steps that you would be happening to achieve in case of you're doing evidence-based medicine. See this topic, you are trying to enter into the PG entrance right now, right? So that is what your aim is. That is what your current objective is. But very soon you will also do research. So this topic may come handy to you then also. So the first step that you beta need to understand is that we formulate the hypothesis, formulate the hypothesis. And in fact, this is the most critical step. It is the most critical step to formulate a hypothesis, that what do you want to study and why do you want to study. Then it is super easy. You identify what all researchers are there. Once you identify what all researchers are there, which have been done using various computer methods we have nowadays. So we don't go to libraries. In earlier times, my seniors, they used to go to libraries to conduct evidence-based medicine. But now we have everything on mobile phones, right? Or even on desktops. So you identify the studies using various search engines, and then you extract data. And this extraction of data and consolidation of data is what is called as abstraction. And this was one of your MCQs in your exam, in your NEET entrance exam also, just 1 or 2 years before. What do you mean by abstraction of data? Then you just take out the useful data, you summarize everything, and then you publish. When we are publishing, we have to be very sure that when we are dissemination of the research is there, it has to be done in a reputed journal, or otherwise there could be evidence of publication bias. So very soon we are going to talk about what do you mean by publication bias, but that is also another point you would like to ponder upon. Based on these steps, you have different levels of evidence-based medicine. So what is the levels of evidence? The level of evidence could be level 1, level 2, level 3, level 4, and level 5 evidence levels which are there. So the first level is the highest level, which is given the highest marks, the randomized trials, which are beautifully designed. Then on the second level, you have the quasi designs. Quasi is a Spanish word. It means partial. So quasi designs means partial, mean either the sampling was not done properly, or the randomization element was not there, or the control group was not very nice, or the attrition was there, or follow-up was there. So anything which is partial. Anything which is partial is called as a quasi-experimental design. Next in line is non-randomized, non-experimental designs, consensus panel, practice guidelines, and last is literature reviews or opinions from different people or different organizations. That is the last level of evidence. Another MCQ which can be asked is regarding meta-analysis is that if you talk about meta-analysis. In meta-analysis, I hope you understand that meta-analysis is a statistical approach. It is better than systematic reviews. In meta-analysis, we draw a graph. We draw a graph or a plot. This plot or a graph is called as a forest plot. This again was your previously asked MCQ. What do you mean by forest plot? Forest plot is drawn in meta-analysis. So what is this forest plot? If you look at this forest plot, this is just an example of forest plot. You can see that various studies are there. So different people, Smith et al., Jones, Smith, NG et al., Chu et al. So different study designs were taken up, different studies by different researchers, and we draw the effect. So what is here over? You can see the lowest effect, and this is the maximum point of effect, and this corresponds to the median effect. It corresponds to the median effect by their study. You remember we talked about odds ratio. So in this study, Smith et al. Gave the odds ratio of 1.3. What does 1.3 mean? 1.3 means it is a risk factor or protective. It is a risk factor. Then 2.1, 1.8, 2.3, 2.1, different studies gave the different answers. So now you want to find out what is the average or the median of the median's effect. Are you able to get it? So Smith gave one median effect, Jones gave one median effect, Smith gave another, NG gave another, NG another. So different, the median of the median's effect, you draw it always by, that is what the MCQ is, you always draw it by a diamond. By a diamond, or this is a rhombus shape. You remember in maths we used to do rhombus, right? So there is a rhomboid shape or a diamond which will tell you what? It will tell you the median of all the effects. So the median is always given by this diamond, and can you see that the median lies somewhere ahead of 2.0 odds ratio? So that we say that out of all the studies from my research, out of these, how many? 5 studies we had taken. So out of all these 5 studies, this is my average effect. This is what we call as forest plot. The next point is again regarding evidence-based medicine. We have something called as Cochrane. What do you mean by Cochrane? It's a collaboration. It's an international collaboration. This is the symbol that you see on the screen. So Cochrane is for evidence-based medicine. It is a collaboration where all the researchers will put their systematic reviews. They will put their opinions about different studies. You take all the studies. They are available online. So you take all the studies and you just study the studies and form your own reviews, and those are published on a Cochrane. You can see inside the logo. Can you see inside? Can you appreciate this? There is a rhombus. It's very small one, and what you see inside is actually a forest plot. What you see inside the Cochrane is a forest plot. It is actually to enable researchers more accessible and more approachable kind of data. That is what is Cochrane reviews. So those were some of the MCQs for evidence-based medicine. Now coming over to topic number 2. What do you mean by quaternary prevention? So these are some of the MCQs which will keep on coming here and there, miscellaneous topics I'm trying to cover in this video. What do you mean by quaternary prevention? Beta, you already know what is a primordial, primary, secondary, tertiary, prevent the risk factor, prevent the disease, complication, all that. You already did that in the chapter of screening of disease. So what do you mean by quaternary prevention? In quaternary prevention, this is a higher level of prevention where you prevent the overdiagnosis or over investigation or over intervention. Over diagnosis, over investigation, over intervention. So anything across the border. So you should not be doing anything which is excess required. So preventing the over diagnosis, over investigation, or over intervention for a disease or health event or health related event is called as quaternary prevention. So primarily you should be very cautious if you are managing a journal or if you're managing an organization which has a reputation. So you have to be careful that we are not making guidelines as such which are going to maybe overdiagnose and harm the patient instead of treating the whole system. So that is what is quaternary prevention. It is, just remember, it is to prevent the overdiagnosis. That is the fourth level of prevention. Next in line, topic number 3 is what do you mean by a publication bias or a file drawer file effect? So what happens is, if you just look at this diagram, can you appreciate what is happening over here? See, this is a funnel plot. What is this called? What you see on the screen? This is called as beta a funnel plot. This is called as a funnel plot. In the funnel, whenever we pour something, it should be always equal. It should be symmetrical, right? So the funnel should have dots. You see the dots over here. These dots represent the results by a research study. So the dots should almost always be equal on this side and that side. What we understand in science is that science is never positive. There always has to be another side of the science. The results should be positive and they should be negative also. You can't have the negative results all time, or you can't have a positive results all time. So you see the problems, you fix them, and again you see another problem. So that's how science works. So anyways, funnel plot is always symmetrical. It should always be symmetrical. There are some research studies which will have more effects on one side. So if you see more effects on one side, that means what? That probably the journal is publishing one type of researches only, or a single type of results from a research only. Probably the journal is promoting one type of evidence only and not the other type. So that is what do we mean by publication bias, where reputed organizations or journals will have, just remember, preferential publications. So that is what we mean by publication bias, or a drawer effect, where some of the researchers have been put into that file drawer. So that is what is a publication bias. Next is topic number 4. What do you mean by operations research? Operation research does not mean that while conducting operation or surgery you did some research. No, it's not like that. So operations research, it is a technical term where you do health systems research. It is a research of the healthcare system, that what is the system we have. Is the system in place? Are the people able to approach a subcenter? Are the subcenter able to refer to the PHC? Are the people actually going to the PHC? Do we need something in between? Are the people going to CHC? Do we need FRUs and things like these? So when you improve the system, healthcare system, that is what we call as operations research. So operations research is about healthcare system, healthcare systems. So you see that how to improve the health facilities, how to improve their utilization, how to promote people coming to your system. That is what is operations research. The next one is point number 5. What do you mean by surgery and clinical trials? I don't want to scare you over here, but surgical branch, if you take a surgical branch or any surgeon is there. Now, if the surgeon is wanting to do a clinical trial, he or she will face a lot of problems. What do I mean by the problems? That is the only understanding you need, especially for your UG curriculum, which has been changed in community medicine very recently. So what happens, beta, is that in surgeries, it is very important that the surgeon, because they are going to open something and they are going to do some surgical intervention, it cannot be redone. So there is no chance of redoing it, no chance of redoing a surgery. It is not possible. So there is a very big problem of ethics. There is a very big problem of ethics, because this whatever trial let us say you want to say, I want to try a new type of surgery. So now the ethical issues will come into place, that maybe that surgery can be successful, not successful, a lot of problems will be there. So one is regarding ethics. Second is that because it's a surgical field and you are doing a trial with the surgical field, there is a very high amount of non-response among the users or among the subjects, non-response or attrition we say. So people will leave your study and go that I don't want to do the study. Let us say your surgical procedure was a 5-step procedure. So you did procedure 1 and then people will have attrition. The study might have attrition. There is a problem of attrition. There is a problem of ethics. Another problem that you might have in surgical fields and clinical trial is regarding the quality. Let us say you are a surgeon and you say that I want to try 2 different types of cholecystectomies. So I'll take 100 patients, I'll randomize into group A and group B or whatever. Let us say you are randomizing and surgeon 1 is doing here, surgeon 2 is doing here, or even surgeon 1 is doing both the surgeries. The quality of, understand the words, the quality of care will not be dependent only on the surgeon. It is also dependent on the nursing staff. It is also dependent on the hands of the surgeon, because surgery is an art, it is a skill. So the hands of the surgeon, the nursing staff, the anesthesiologist, there are so many team players. It is a team work. So the quality standardization comes as an issue when we are trying to compare different surgeries, because surgeon 1 might be better than a surgeon 2, with due respect. So the quality standardization, non-response, attrition and ethics, these are some of the important problems which are faced in surgical fields and clinical trials. No MCQ, just for UG purpose. This has been included in your curriculum for community medicine, and that's why it's here in your edition 6 Marrow videos. Now coming over to point number 6. What do you mean by deductive approach or deductive research, and what do you mean by inductive approach or inductive research? See, I know these words might sound very unfamiliar and very uneasy to you, but that's how community medicine is. These have been recent inclusions in your competency-based medical education curriculum in community medicine. So these are some things which may be asked in your exam, and that's what is Marrow Edition 5 updated videos for you. So deductive research, what do you mean by deductive? Deductive means to deduce something. So beta, there already is some theory. So that theory is established. It is there. We know that giving iron will treat anemia. So I have a theory, and based on the theory, I will formulate a research question. If I formulate a research question based on the theory and then I do my research to find out, to validate whether the theory is correct or not. Of course, theory is a theory, but you go from top to the bottom. So there is a theory and then you formulate a research. That is what is a deductive type of research. What do you mean by inductive? Inductive means something which induces you, something, there is a fire inside you. So that is what is inducting, something which ignites inside you. I'm a pro researcher into inductive research. What do you mean by inductive? Where you don't have any theory, there is no rules for us. So we try to see that what is all this. So where you make some hypothesis, you do research based on a hypothesis, and then you find the results that yes, this actually works, and then you formulate a theory. That is what is inductive. That is what is an inductive research. So basically in inductive, you go from bottom to the up. So you go from bottom to up approach. Inductive is bottom to up, whereas deductive is up to down approach, or up to bottom or top to bottom approach. That is what is deductive. Next is point number 7. What do you mean by qualitative research and what is a quantitative? Quantitative, if you have watched my biostats videos, we talked about what do you mean by a qualitative data and a quantitative data. Quantitative is something which you can quantify, which you can numberize, which you can measure. So quantitative research will be talking about quantitative. It is quantifiable, where you do some measurable outcomes are measured, measurable outcomes, and there were measurable inputs. So in a quantitative research, I will give 50 grams of glucose, then I will see how much blood sugar increases, how much C-peptide level increases, how much insulin is secreted. I will give 50 grams of sulfonylureas, then I will see whatever you want to do. So there has to be a quantifiable number and there has to be quantifiable output. Input and output has to be quantified. So I'll give 5 milligrams of zinc. I will see what is the diarrhea. I'll give 10 milligrams of zinc. I'll see what is the diarrhea. I'll give 20 milligrams of zinc. I'll see what is the diarrhea. I'll give 10 milligrams of cobalt. I'll give magnesium, whatever I want. This is what is research. This is what is science. This is what is a quantitative research. But quantitative research has to be done only after qualitative research. Qualitative research will formulate a question that can maybe giving some minerals help in diarrhea. So basically qualitative research has no measurable outcomes. It is basically based on group discussions. It is based on opinions. It cannot be quantified. So that is what is a qualitative research, which is primarily based on group discussions. And when we do focus group discussion, that is what happens is we formulate a research problem. So we say that probably this is a research problem. That is what is a qualitative research. So if we all sit down together and say that we've got a lot of anemia in our area, so what could be the reason, and do focus group discussions, that is what is a qualitative. But now based on that qualitative, let us say the researcher will give some iron folic acid, they will give some spinach tablet, something they will do. So to promote the HB levels in people. So actually that is what is a quantitative research. The point number 8 is regarding validity of study. In screening of disease, we already discussed about validity. That means accuracy means getting the true value or the center point, getting the real value, but validity was getting the results within a defined range, right? So validity of a study in epidemiological words, they also, the concept is actually the same. So what do you mean by validity? Validity beta is of two types, internal validity and we can have a external validity. What do you mean by internal validity? Internal validity means that on repeated measurements or repeated study designs in the same population, if there is a population, you give some intervention and you're getting some results. In the same population, if you give the same intervention, should you get the same results? That is what is internal validity. On repeated measurements, do you get the same results? It roughly corresponds to the precision that you are getting the similar results again and again, but it has to be in the same population. So MCQ which can be asked to you beta is nothing very hi-fi. Internal validity means it is dependent on what? It is dependent on what? It is dependent on the epidemiological methods that we adopt. It is dependent on the robustness of a study design, that how good your design is. It tells you about the methodology which was taken. What do you mean by external validity? External validity means that if I do a research in this population using this intervention, now I do a research in another population using this similar intervention. You do a study in Delhi and you do some intervention, you get some HB results or blood pressure changes. You do the same intervention in Manipur. You do the same intervention in Jammu Kashmir. You do the same intervention in Kerala. So will you get the same results again and again? So that understanding is called as external validity. It means generalizability. It means generalizability. That is your study generalizable? Can it be expanded to bigger populations? So it depends on what? Will it depend on the robustness? Robustness will tell you about the internal validity of a system. The external validity is determined by the sample size, how big your sample is. So the sampling methods, the sample size is it's one of the main determinants of external validity. So these are just 2-3 MCQs you get on validity of a study design. Point number 9. Last point is guidelines in epidemiological methods. So in epidemiological methods, we have various governing bodies, we have various authorities which are going to help us to guide all this. So what do you mean by consort? Consort is Consolidated Standards of Reporting Trials. It is for experimental designs. So beta, if you are planning to do an experimental design in very soon in your PG entrance, you will do some studies. So if you are planning to do experimental design, you will have to adhere to the consort guidelines. You go to online, Google and whatever, and you type in consort, you'll get a set of rules which have to be adhered when you are planning for experimental design. This is what we are talking as the guidelines in epidemiological methods. Another is STROBE. STROBE stands for the strengthening of reporting of the observational study. So in case you are doing observational study designs, you will follow the STROBE guidelines. Next is PRISMA. That is for preferred reporting items for systematic reviews and meta-analysis. That is primarily for evidence-based medicine. Then you have CARE, that is for quality control in case reports. And the next one is SRQR, that is standards of reporting for qualitative research. So for qualitative research, just remember SRQR. Then you have SRDA, that is for standard of reporting of diagnostic accuracy. So basically for investigations where you are doing a research to investigate the disease much early, you do SRDA. And then we have SQIRE, Squire. The Squire is done for any type of research method where you have quality improvement of reporting excellence. So beta, just remember these are some of the guidelines for epidemiological methods. And so with that, thank you so much for watching this video. In the next one, we will talk about the bias and confounding and errors in epidemiology.